Okay, so on to the midfoot, involving all three cuneiforms, cuboid and navicular. And looking at the differential slide, the focus will be mainly on bone and joint issues, though we do touch on some other soft tissue conditions as well. Starting with the first slide of the cuboid and navicular fracture, they were combined on one slide, but obviously two distinct entities. In particular, navicular fractures can be described as dorsal avulsions or avulsions of the tuberosity and fractures of the body. Cuboid fractures are often associated with other injuries as well, the tarsal metatarsal joint and metatarsals as well. Main differential here, looking at things along the lines of navicular stress fractures, not confusing this condition with an accessory ossicle of the navicular or cuboid. Other more substantial midfoot traumatic injuries should be certainly considered in the context of significant trauma. The management of navicular fractures really vary various degrees of immobilization and weight bearing as tolerated. Certainly, referral is indicated for displaced fractures of the navicular body, non or delayed unions, persistently painful dorsal avulsions or tuberosity fractures, and tuberosity fractures that are greater than 1 centimeter, that demonstrate greater than 1 centimeter proximal displacement, as well as large displaced dorsal avulsion fractures. Certainly with other associated injuries, referral would be potentially indicated in those cases as well. Navicular stress fractures, more typically presenting to your office, really focusing in on a watershed area in the middle third of the navicular. Important to remember. Again, not overlooking factors that lead to a stress injury, such as training errors, overuse, and screening for REDS are important. Really important to remember cervix anatomy in this case and consider this in your differential when someone presents with medial midfoot pain with your clinical exam supported by imaging with respect to ordering a bone scan or MRI if needed. Important to remember the recommendation of strict non-weight bearing in a cast for 6 to 8 weeks and until no further tenderness, and then a graduated return to activity, which can be quite prolonged, more so than potentially other stress fractures of the forefoot. But certainly if the tender ovonavicular assume a stress fracture given the clinical context until proven otherwise. One of the main differentials to consider when we reviewing imaging, especially and as well with when people present with pain over the navicular, is an accessory ossicle in this area. And as a congenital issue, though pain can develop in these areas due to irregularities at the insertion point of the tib post or with open growth plates at the apophysitis, or at the apophysis with respect to apophysitis. Certainly they can be found incidentally, but also when it comes to reviewing fractures and symptomatic lesions, one has to think of this as the differential, whether you're seeing or dealing with a true fracture or pain secondary to this accessory ossification center. Treatment could be none if incidentally noted and you're confident that it doesn't represent another injury, and certainly varying degrees of treatment there otherwise if symptomatic. Cuboid syndrome, thought to be related to a cuboid subluxation, and as a result of associated conditions with respect to the perineal tendons, often seen in jumping athletes, ballet dancers, runners, etc. Certainly want to keep in mind the possibility of cuboid fracture, stress fracture, as well as perineal tendinopathy. usually pain localized over the cuboid and tenderness, along with possibly excessive pronation or lateral ankle instability. One of the things to consider on a differential when thinking, again, of an inversion injury or lateral hind or midfoot pain after an injury that isn't responding to the appropriate treatment or time frame. The one would think recovery should have been completed from a simple ankle sprain. Treatment, limited evidence to support cuboid manipulation, and certainly very limited evidence in this regard, and or supportive footwear or orthosis. Moving on to tarsal coalition, often either discovered again incidentally or even though congenital lesion, often presenting later on with increased sports participation in potentially the teenage years or older children, or sometimes noted when X-ray is done for another reason and is discovered. And on exam, you certainly can find reduced subtalar or mid-tarsal joint active and passive range, sometimes with pain at that end range. 50 and 60% are bilateral, remember, and most commonly at the calcaneal-navicular and the talocalcaneal junctions. Most would be evident on X-ray if we're talking about a bony union rather than a fibrous coalition, and treatment directed at optimizing biomechanics of the foot and ankle, as well as trying to mobilize and support the surrounding joints with or without orthoses. Kohler's disease, good condition to keep in mind and remember, is in a pediatric population, presenting typically between the ages of 2 to 8, possibly an overuse or idiopathic injury, and indicative of an AVN of the navicular. You have, in these cases, a child presenting with a limp, pain and tenderness over this area, with findings, evidence on X-ray in a number of cases. Treatment as the mainstay of managing this condition would be weight bearing as tolerated in an AC boot for approximately 6 weeks. Moving on to a traumatic injury, quite common Lisfranc injury, certainly something not to be missed and important to remember. Grading here between 1 and 3 has impact on your management strategies. Grade 1 being a sprain without diastasis or fracture, being managed with non-weight bearing and an air cast boot for 6 weeks or so, followed by a graduated return to sport under supervision of physio and rehab, and more severe grades of injuries, often requiring some sort of surgical intervention or at least orthopedic consultation. The mechanism usually involving low velocity indirect force really should be considered when you hear or see an athlete or an individual with a diagnosis of quote midfoot sprain, unquote. It could also result from a direct simple crush injury and mechanism of injury as well, either falling on the point of the toes, most classically, or falling backwards. Patients will, especially if presenting late or swelling and bruising has subsided, report pain in the midfoot area with push-off, calf raises, toe running, etc. Certainly remember this in your delay presentations as well. Definitely X-ray findings that should be remembered and often important to compare to the uninjured foot, and remember that getting views that are weight-bearing may help you with this diagnosis. First and second metatarsal diastasis greater than 2 millimeters or 1 millimeter asymmetry between the unaffected side. Also, remembering your normal alignment of the midfoot and the Lisfranc joint is really important to spot subtle abnormalities that may go unnoticed, if not really paying close attention. Flex sign, which is a small fracture off the base of the second metatarsal, also something to look for, as well as dorsal displacement at the metatarsal base on the lateral view of the foot. and certainly low threshold for further imaging in these cases would be appropriate to search for occult fractures and or soft tissue injury with CT and or MRI. Important one not to miss and one to remember. Moving to extensor tendinopathy, most commonly of the tibialis anterior, but could involve any of the extensor tendons of the foot. We see this often with, again, overuse, overloading type of situations, extensor muscle and tendon weakness, changes in training load, training errors, etc. Often we see in conjunction with external compression, often in the case of skaters in hockey or with shoelaces, leading to a common condition known as skate bite. Clinical exam usually sufficient, but ultrasound or MRI in complicated cases or if you're unsure, and physio, relative rest, soft tissue therapies, certainly addressing any underlying factors that could have predisposed to this. Sometimes external padding or changing in equipment might be beneficial. Okay, so moving to pes planus, very common, of course, and commonly flat feet with moderate or complete loss of the longitudinal arch. Can be classified clinically, which I thought was more appropriate and useful, looking at either a rigid or a flexible condition here, which would then ultimately help you decide what to do when you see this in the office. Rigid pes planus really demonstrates decreased tarsal and subtalar range of motion and no real change when you have the patient perform a heel raise. A flexible condition would see a reappearing at that longitudinal arch when the foot is suspended, i.e. when they're sitting on the exam table or with a heel raise as it moves out of valgus. For rigid pes planus, you want to look for associated conditions such as a tib post dysfunction or previous tear or spring ligament tear that may have gone undiagnosed. Certainly underlying tarsal coalition and a referral if symptomatic and as appropriate thereafter. Whereas a flexible pes planus condition can be further subdivided in type 1, 2, or 3, with type 1 being a functional flat foot, which is not usually painful, though can be supported with good footwear and further rehab based on other predisposing factors to really decrease the functional pronation that can then subsequently lead to other foot and ankle conditions. Type 2 flexible pes planus would be indicative of a hypermobile flat foot with ligamentous laxity and tight heel cords, and this is certainly something to consider as part of a condition like Ehlers-Danlos, Marfan's, osteogenesis imperfecta, any of familiar or syndromic type presentation, also with tarsal coalition and accessory navicular. And treatment would be really a referral for if there is an underlying condition, thinking about these conditions, if this presentation fits, and a stretching program for the Achilles and gastrocnemius complex. Whereas type 3 flexible pes planus really is associated with that grade 2 tib post dysfunction. Really, and these patients are unable to perform a heel raise, but their subtalar joint will still be mobile. And treatment being a combination of rest, NSAIDs, support, physio, and occasionally a period of weight bearing as tolerated and some sort of immobilization like an air cast boot or an ankle stabilizer brace with subsequent referral if really we're not seeing improvement over a few months or so. An X-ray SVT can help with the diagnosis when it comes to coalition, whereas an ultrasound or MRI can help you with assessing tib post dysfunction, injury or tear, tenosynovitis, and sprague ligament integrity. Really, when it comes to pes planus, a lot of people, this is not a pathologic condition. However, certainly as a predisposing factor to some conditions, as well as if acquired and asymmetrical, certainly should lead you towards looking for other possible causes and conditions that would require various treatments. Looking at pes cavus, the opposite end of the spectrum, defined really as an elevated longitudinal arch due to plantar effects mid and forefoot on the hindfoot, often associated with claw toes. If idiopathic, often stable, but can also be progressive as secondary to potentially a neuromuscular disease. And even idiopathic cases can present with gait abnormalities and other secondary issues like metatarsal stress fractures, ankle instability, skin conditions, metatarsalgia, etc. Really, when it comes to pes cavus, looking for underlying conditions, especially if progressive, it really should be your focus. And assessing this in various degrees, in various ways, whether it be stable, flexible, and looking for associated conditions or associated abnormalities that may point you one way or the other when it comes to differential are really important. If obviously a neuromuscular disease is suspected, further referral, imaging, potentially EMG, nerve conduction studies, looking into the lumbar spine for spinal cord lesions, i.e. tethered cord, considering peripheral nerve conditions like Charcot-Marie tooth, etc. Really important. And management of this condition certainly obviously depends on the underlying severity, symptomatology, possibility of underlying associated conditions. By looking at orthotics, footwear modifications, appropriate footwear, stretching of the calf and plantar fascia, and referral in some cases if, again, your history, physical, and presentation suggests some other underlying cause.